Welcome back to part 24 of our IPDRG Masterclass. I'm Harshal, your lead instructor, and today we're jumping straight into Group 5 of the ICD-10 PCS root operations. But real quick, if you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Okay, let's take a super quick look at today's Masterclass roadmap. We'll briefly recap our last lesson, tackle restriction versus occlusion, dive right into dilation and device coding, and then finish up by mastering the bypass.
All right, Section 1, recap of Part 23.
So remember back in Part 23, we covered the Group 4 operations. We were talking about transplantation, reattachment, transfer, and reposition. The whole goal there was physical relocation, right? Putting things in or moving them around to their normal or suitable locations. But today, with Group 5, our clinical objective completely shifts. We're no longer moving body parts around. Instead, we're focused on altering their diameter or changing the actual route of their contents.
Moving right along to Section 2, closing it up, restriction versus occlusion.
This is the crucial distinction you absolutely need to memorize today. When you're reading through an operative report and the surgeon is closing a tubular body part, you have to ask yourself one question. Is this partial or is it complete? Partial closure always equals restriction. Complete closure always equals occlusion. It's a simple binary choice, but nailing it is essential for your DRG assignment accuracy. Let's zoom in on restriction first, which gets assigned the character value V in the medical and surgical section. You can think of restriction as merely narrowing the diameter of a tube. The physician isn't stopping the flow entirely, they're just restricting it. And keep in mind, this narrowing can happen intraluminally, meaning from the inside of the tube, or extraluminally, from the outside. To put that into some clinical context, when you see a procedure like an esophagogastric fundoplication in the operative report, your brain should immediately flag that as a restriction. The surgeon is wrapping the stomach around the esophagus to narrow it and prevent acid reflux. They definitely aren't closing the esophagus entirely. Another classic example is a cervical cerclage, where the cervix is narrowed to safely maintain a pregnancy. On the flip side, we have occlusion, which uses the character value L. This means we are completely blocking the passage. There is zero flow happening after an occlusion. The primary clinical objective here is total, complete closure. So, whether a surgeon is doing a fallopian tube ligation to permanently prevent a pregnancy, or maybe an interventional radiologist is using embolization coils on a uterine artery to stop a hemorrhage, the intent is total blockage. Both of those clinical scenarios code straight to occlusion because the passage is completely closed off.
Let's look at the flip side. Section 3, opening up, dilation and devices.
Now, what if the clinical objective is the exact opposite of what we just talked about? Dilation, which is represented by value 7, is all about expanding an orifice or the lumen of a tubular body part. The goal is to stretch a narrowed or stenosed lumen, and they usually achieve this using intraluminal pressure. Think of deploying a balloon catheter inside a vessel or duct to literally force it open. A brilliant illustration of this is a percutaneous transluminal angioplasty, or PTA. This common procedure maps perfectly to dilation. If you're mapping a PTA of a peripheral artery to 04C03ZZ, just remember that while dilation is value 7, the core objective is always expansion, no matter which specific vessel they are targeting. We've got to talk about devices here too, because they go hand in hand with dilation. There is a golden rule for device coding. If a stent, like a drug-eluting intraluminal device, is left behind to maintain that expanded diameter, you absolutely must capture it in character 6. If they just inflate a balloon to dilate and then pull the balloon out, your 6th character is Z for no device. But if that stent stays in the patient's body, character 6 has to reflect it. Next up, Section 4, rerouting, the art of the bypass. A bypass, which takes value 1, fundamentally changes where the contents of a tubular body part flow. In this case, we aren't just opening or closing an existing pipe. We are physically rerouting the plumbing to bypass an obstruction or some disease segment. To code a bypass accurately, you have to master this specific guideline. According to standard ICD-10 PCS rules, character 4 dictates the origin, meaning where we bypass from. And character 7, the qualifier, dictates the destination, where we bypass to. So for a gastric bypass, character 4 is the stomach, and character 7 might be the jejunum. From the stomach to the jejunum. Super simple, right? Well, mostly simple. This actually brings us to a notorious coding pitfall. How on earth do we handle a coronary artery bypass graft, or CABG, when multiple arteries are involved? Think about it. If character 4 is the from site, how are we supposed to list 4 different coronary arteries in a single character space? Here is the massive exception you absolutely need to write down. In the coronary artery bypass exception, character 4 identifies the number of arteries bypassed, not the anatomical origin. Take a look at the 7-character breakdown for a CABG, right there on your screen. O2100JZ. That O in the 4th position doesn't mean a specific piece of heart tissue, it actually means coronary artery 1 site. If they bypass 2 arteries, that character would be a 1. Then the 7th character qualifier steps in to tell us where the blood is coming from, like the aorta. So the logic is completely flipped for coronary arteries. Whenever you feel stuck navigating these complex procedures, just ground yourself in the basic 7 characters. Ask yourself, why is the surgeon doing this? That's your root operation. Where are they working? That's the body part. How did they get in? That's your approach. And what did they leave behind? That's your device. If you map out the why, where, how, and what, this coding logic becomes an absolute breeze. Mastering these nuanced differences between restriction, occlusion, dilation, and bypass is absolutely going to transform your DRG assignment accuracy tomorrow. But here's something to think about. What happens when a bypass actually fails and a surgeon has to go back in to take that device out? We'll be tackling that exact nightmare scenario in our next explainer. If you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding, and I will see you next time.